Hi, everyone. Welcome. I think we have a quorum. I'm so excited to be chatting to you today with a case-based approach to reproductive endocrinology. I think I placed it in the chat, but I am looking forward to a really interactive session. And please feel free to put questions in the Q&A or in the chat as they arise. And I will just go ahead and get started. So the first case is someone coming to you for fertility management. So it is a 32-year-old Caucasian woman with a history of PCOS and obesity. She was diagnosed with PCOS based on irregular menstrual cycles, so she had only 3 spontaneous bleeds per year and hirsutism, and she has since lost 20 pounds since her diagnosis. She is currently on spironolactone, 100 milligrams BID, metformin, 750 milligrams BID, semaglutide, 2.4 milligrams weekly, and norethindrone ethinyl estradiol, 1 milligram, 20 microgram pill, and her hemoglobin A1C is 5.8%. So I am going to say that what she did not, she told you as you're reviewing all of her meds, oh, but I was so excited to start trying to get pregnant. I stopped my birth control pill a month ago. So what do you recommend that she do with her spironolactone, metformin, and semaglutide? So I'm going to give you the answers, and then I'm actually going to launch a poll question for it. The first is continue her spironolactone, metformin, and semaglutide. B is continue her metformin, but stop her spironolactone and semaglutide. C is continue the semaglutide, but stop the metformin and the spironolactone. D is stop all of the medications. And E is continue the spironolactone, but stop the semaglutide and the metformin. So I'm going to go ahead and launch the poll. And I'm going to give everyone a chance to answer the poll question. And then we'll take a look at the answers. Wonderful. So we've got a lot of people who participated. I'm going to go ahead and share the results of that poll. And I think what you can say is the vast majority of people were like, hey, let's continue the metformin, but stop the spironolactone and the semaglutide. And we had someone who was like, oh, just stop them all. Okay. And so what I'd like to do now is to go back and actually, Ashley, can you just make sure I've stopped sharing that poll so it's not in everyone's screen? What I'd like to do now is talk to you about the different pieces. So you absolutely want to stop the spironolactone. So there are studies, particularly animal studies, that exposure to spironolactone in vitro feminizes the male offspring. The most common thing that you might expect to see is a hypospadias. What I can tell you, however, is that there have been a handful of cases of human males in vitro, in utero, exposed to spironolactone. And at some doses that are quite high in terms of total daily dose, and they have had normal genitals at birth, and at least one of them has been followed through to show normal puberty. So although I still certainly caution all of my patients, and I certainly stop it prior to pregnancy, this is, I think, more of a theoretical possibility than something we routinely see. Metformin use in contraception is actually a little more controversial. And I know that the 2023 international guidelines suggest that metformin could be used as a secondary use option in patients with PCOS who are challenged with fertility. But I will tell you there is the large randomized controlled trials, and well as some of the meta-analyses, suggest there's really limited to no benefit for infertility. There's no clear benefit when you add it to clomiphene citrate or letrozole, and there really is no clear benefit with your patients who are going to in vitro fertilization. The one caveat, the one caution with that is women at high risk for ovarian hyperstimulation syndrome do better on metformin. It helps prevent the OHSS. The general theory is that you would continue metformin in obese women with prediabetes. This is individuals with impaired fasting glucose, impaired glucose tolerance, and true prediabetes just by hemoglobin A1C is much more controversial. There are some people, even with an impaired fasting glucose or impaired glucose tolerance, who would stop the metformin and check lab values. Most people would say that metformin should drop your A1C by about 0.5% at full dose. And if they're on full dose and have an A1C of about, 5.9%, there's a decent chance they're going to be diabetic when you pull it off. The reason why you want to be careful about it is because in non-GDM, in patients who do not have gestational diabetes, metformin may reduce maternal weight gain during pregnancy. It may reduce preterm birth during pregnancy with PCOS, but there's no benefit for gestational diabetes prevention. So you're not going to prevent gestational diabetes. And metformin-exposed children, on the opposite side, have actually accelerated postnatal growth, kind of catch-up growth. And as a result, you have heavier infants and higher BMI by mid-childhood. We actually don't yet have the full scope of answers in terms of what's going on with these children, right? So these children right now are about 7, 8, 9 years old that are in this cohort that they're continuing to publish on. But we do know that both of these outcomes are associated with adverse cardiometabolic outcomes long-term. So when we return to this question, I think the question about continuing the metformin, which I think everyone was like, let's do that, versus stopping the metformin, actually hinges on our understanding of her A1C of 5.8%. So I think we would need to do more work on that to understand what's going on. I want to take a moment, however, to talk about GLP-1 receptor agonists in pregnancy and lactation. These are extremely effective weight loss agents. More and more people are turning to them for their use. They are absolutely contraindicated in pregnancy. So semaglutide has a 7-day half-life, which would be a 2-month washout. Liraglutide has a 13-hour half-life, which would be a 1-month washout. But I will tell you in general, our weight loss colleagues are telling us that they like a 3-month buffer between any use of these medications and any possible pregnancy. Why? So in pregnant rabbits, when they were studying them, there were early pregnancy losses, as well as some minor changes to both the kidney and the liver. There were also skeletal changes, and they were observed at really just a fraction of the maximum recommended human dose. And in pregnant monkeys, they also saw early pregnancy loss and small for gestational age infants at about 3-fold the maximum recommended dose. It is also detected in the milk of rats. We don't know its impact on developing infants, so I would not recommend it during lactation either. Tirzepatide is not a pure GLP-1 receptor agonist. It also is a GIP-1 receptor agonist, and it also needs to be stopped. So where we are is we're stopping the semaglutide, we're stopping the spironolactone, and we're in this, do we or don't we stop the metformin? And so this really gets into what kind of testing you would order. And so people can feel free to put your thoughts in the chat as you think about what kind of testing do you want to order in this woman with PCOS and obesity. And I think Alice has already, I'm already seeing everyone come up with absolutely OGTT, right? Because that's going to tell you more information about what to do with that metformin than anything else. You want to remember your preconception goal for your fasting glucose is less than 110 milligrams per deciliter in patients who have type 2 diabetes. So I consider a fasting glucose under 110 is what I'm looking for during the OGTT. I'm also looking to see whether or not they have significant impaired glucose tolerance on the metformin already, which, like we said, would be an indication to continue the metformin into pregnancy and to conduct an early OGTT during pregnancy to formally assess for gestational diabetes. She's also in your clinic wanting to get pregnant. And so the general recommendation is that you should check an HCG because she actually stopped her birth control pill a month ago. She actually could already be pregnant. You want to check her RH status. She has PCOS and she has obesity. Obesity is associated with an increased risk of miscarriage. If she is RH negative and she miscarries, she may need RhoGAM. So you want to know what her RH status is so that if she calls you and says, hey, I am pregnant and I'm miscarrying, you can talk to your OBGYN colleagues and tell them what to do. You want to do a sexually transmitted infection panel. This is particularly important as we've seen a rise in the number of cases of neonatal syphilis, and MMR, hepatitis B, and varicella. There's now formal guidance on potential booster shots, particularly for varicella or within the MMR series if you don't see immunity. You want to check her blood pressure. PCOS and obesity is associated with an increased risk of hypertension, pregnancy-induced hypertension, and preeclampsia in pregnancy. You want to check a thyroid function test. And then I want to really encourage you to think about genetic testing. Late onset congenital adrenal hyperplasia looks like PCOS. It looks like PCOS. And if someone has not had a normal 17-OH progesterone, they may still have late onset CAH. Even if they don't have late onset CAH, they may still carry at least one allele for CAH that may be modifying their PCOS phenotype. And the final thing is you want to ask about miscarriage, prior pregnancy complications, history of blood counts, and mood disorders. And I see Katie has asked, would you hold the metformin for a certain amount of time prior to getting the OGTT? You know, I think you could debate, do I hold it for 2 weeks and then do the OGTT, or do I do the OGTT on metformin? It probably would depend upon the level of dysglycemia I thought existed in the patient. If I knew they weren't pregnant, I might be tempted to hold it for 2 weeks and check, but you certainly can do it on the metformin. It's important to recognize that a lot of this has to do with how invested the patient is in getting all of this lab testing done, because the most important thing is actually to get the OGTT, whether they're on or off the metformin. So what advice would you give for the patient regarding her desire for fertility? What are you going to recommend? Her history is, I have PCOS. At the time I was diagnosed, I had about 3 periods per year, and she's currently obese. What could you tell her to expect? So she has lost 5 to 10% of her total body weight with semaglutide. We talked about that. The problem is she's off it. So she's now at high risk to regain all of this weight. And you really actually don't want her regaining all of this weight during pregnancy because that's excess pregnancy-associated weight gain. So you want her to exercise for about 30 minutes a day, 5 days a week. Resistance training, we now know, is critical for helping to maintain muscle mass and helping to maintain the appropriate metabolic output. You also want to talk about the increased risk for maternal and fetal complications. You want her to know that they exist. 1, so that you can indicate to her OB that she's a higher risk pregnancy. And 2, so that both she and the OB will monitor her a little more closely. So when we think about potential complications of obesity and pregnancy, how do we think about that? Well, we have lower fertility and preconception. During pregnancy and delivery, we already talked about the gestational diabetes, the gestational hypertension, and the preeclampsia. We have not yet talked about the failure of labor and the increased rate for C-sections, or the increased rate for preterm birth. And you note it says especially the medically indicated, and that really is because of the gestational hypertension and the preeclampsia. There is an increased risk for miscarriage and stillbirth, an increased risk for neural tube defects, for gestational age infants, and for intrauterine growth restriction. And finally, particularly in for gestational age infants, there's an increased risk for shoulder dystocia. Postpartum, there's an increased risk for postpartum depression in the mother, troubles with blood clots and wound healing, and your sort of metabolic dysregulation that we associate, including the failure to lose the weight during pregnancy. There's also increased adiposity in the child, and the child is less likely to be breastfed, which can be associated with the child being leaner. The mother long-term, if they develop gestational diabetes, they have a 50% chance of becoming a type 2 diabetic within the next 5 years. You have obstructive sleep apnea, and for the child, we already talked about some of the obesity and metabolic things. We also see an increased risk for cognitive disorders and asthma and autoimmunity. So if this patient is not pregnant, what ovulation induction agent would you recommend? And so feel free to just type it into the chat. What are the things that you are telling your patients that you want them to take? Oops, I gave it away. Letrozole. Letrozole is the go-to thing that you're going to use. It's now 10 years since we've had the landmark case that has shown letrozole has a significant advantage for obesity. So what I'm showing you here is the percentage live birth rate. With letrozole, it's about 25%. With clomiphene, it's about 15%. That's an enormous change for patients who have BMIs between 30 to 39. And you may say, wait a second, Meg, aren't you getting way ahead of yourself, right? This patient just stopped their birth control pill. They're under the age of 35. Shouldn't we wait a year to see if they get pregnant on their own? In patients who have a prior history of cycling only about 3 times a year, there's really not an indication to wait for them to say, aha, now I'm not cycling and I've only had 3 cycles in a year. There's really not an indication to wait when it comes to their fertility care. All right, on to the second case. Again, any questions can be placed in the chat. So case 2, irregular menses. So we have an 18-year-old woman of Han Chinese ancestry who report 8 menses per year and mild acne. She had menarche at age 14. She's on no medications. Her BMI is 24. She has a modified Felmrin-Galway score of 3, no abdominal or pelvic masses, and no virilization. So what is the most likely diagnosis in this patient? Feel free to just type it in the chat. The most likely diagnosis in this patient is PCOS. This is just a reminder that PCOS looks different across different ethnicities. PCOS is a diagnosis of exclusion, and it's characterized by 2 of 3 criteria. These criteria have been modified within the past year by the new international PCOS guidelines. So the oligoanovulation is now at least 3 years after Menarche, menstrual cycles less than 21 days or greater than 35 days, or less than about 8 cycles per year. Documentation of failure to ovulate by a low mid-luteal phase progesterone. Clinical or biochemical hyperandrogenism, which includes acne, hirsutism, or female pattern hair loss, and elevated androgens. Mainly it's testosterone, but it also could be DHEAS or androstenedione. And finally, for polycystic ovarian morphology, this is the biggest change. It depends on ultrasound technology. For older ultrasound technology, we used to say greater than 12 follicles in an ovary, and particularly the early follicular phase. Now the answer is actually greater or equal to 20 with the improved ultrasound technology. And there was a new addition that an elevated AMH could be substituted instead for the polycystic ovarian morphology. So this new updated level is something that we still don't have a number. If you told me, Meg, what's the number of AMH at which I can say my patient has PCOS? I would say we don't know that yet. I'm anticipating we're going to get data in the next 1 to 2 years that's going to help us define that number. In terms of streamlining the algorithm for diagnosis, this is the #1 thing that was recommended. If the patient has irregular cycles and clinical hyperandrogenism, if you exclude the other causes, they have PCOS. You don't have to go searching. If there's no clinical hyperandrogenism, you want to look for biochemical hyperandrogenism. And if they only have irregular cycles or hyperandrogenism, that's when you go ahead and take a look for polycystic ovarian morphology. And this is just a reminder of the other causes that you might possibly need to exclude. In terms of cycle history, I just want to talk very briefly about patients that you may see who may be menopausal, who may say is now experiencing a lot more female pattern hair loss and may say, I read that was associated with PCOS. Do I have PCOS? So when we think about this, we think about it by age. So for adolescents, primary amenorrhea at age 15 or greater than 3 years post-thelarchy is consistent with PCOS. Greater than 1 year past menarche, any 90-day cycle, and greater than 1 or less than 3 years after menarche cycles that are less than 21 or greater than 45 days. And then after 3 years, this goes from greater than 45 days to greater than 35 days. For adults of reproductive age, the oligoanovulation may improve as women go past the age of 30. So they may tell you that for all of my 20s and 30s, I had 6 cycles per year, and now I'm having 8 or 9 cycles per year, but I still have the biochemical hyperandrogenism. That is still consistent with a diagnosis of PCOS. We think there is something about the falling ovarian reserve that mitigates some of the oligoanovulatory phenotype in PCOS. And adults during menopause, we can rely on their reproductive history. If they give you a good reproductive history, you can use that as a criteria for PCOS. So the final question is, how would you interpret her Ferriman-Galway score? So I know you notice I said she's of Han Chinese ancestry, and someone might say, why are you talking about someone's ancestry when you're giving a talk about PCOS? And that's because this Ferriman-Galway score, i.e. how hairy are you? Because all of us have a certain amount of hair. And this comes from the Journal of Clinical Endocrinology Practice Guidelines, varies by ancestry. So in the US or UK, Black or white women greater than or equal to 8 is probably hirsute or hairy. If you're Hispanic or Middle Eastern, it's probably greater than 9 to 10. South American, probably greater than 6. And for Asian, Han Chinese is greater than or equal to 2, but Southern Chinese women is greater than or equal to 7. And I'm sure you're going to say, I don't see a lot of other ancestries on here. You would be correct. Based upon where you live in the Indian subcontinent, the answer is probably somewhere between the US, UK numbers and the Hispanic and Middle Eastern numbers for women. So there's not one thing for the entire subcontinent because it's just so different in terms of ancestry from north to south. So we just talked about the testing, right, in terms of what testing we would order. It's a diagnosis of exclusion. So what are some of your go-to tests that you order for patients when they have irregular menstrual cycles and they present to you for evaluation? So some of the things that you can use, for example, you want to look at non-classical CAH, which we have already talked about. 17-OH progesterone, absolutely right, absolutely right. And this ideally is an early follicular phase because, you know, it is higher during the luteal phase. But to make it easier for my patients, I really like to pair it during the paired progesterone. I find that makes it much easier, you know. And then I can already see absolutely key things, right? Thyroid disease, TSH, Angela puts in, prolactin, AM prolactin, pregnancy, HCG, right? Your core things that you're thinking about. Hypothalamic amenorrhea, if you think they're somehow thin. POI, androgen secreting tumors, if you're concerned about them, would be a serum T and DHEAS. Ovarian hyperthecosis, more common in postmenopausal women, can be seen in premenopausal women. When seen in premenopausal women, have high testosterone levels. We're typically looking at testosterone levels that are over 100 nanograms per deciliter and are associated with marked metabolic dysregulation and prediabetes, Cushing's syndrome, and acromegaly. You'll notice AMH is not on this list. Either AMH or ultrasound can be used as a criteria for PCOS. We know women with elevated AMH levels that go into IVF are at increased risk for OHSS. So I would say it kind of depends on your index of suspicion, sort of when you might order an AMH level. Although AMH declines with age, and we do think with lower AMH levels comes an increased challenge with fertility, there are no clear cutoff values for AMH. There are no clear cutoff values for AMH for the diagnosis of menopause. There are no clear cutoffs for AMH for the diagnosis for PCOS. It is a continuum, and most of the data on AMH to date has been done in IVF centers where people are already presenting with infertility. And we know there are sort of community dwelling women who are out there with AMH levels that are able to conceive just fine. We do think there is a fecundity deficit as AMH declines, but there's no particular line at which we could say your likelihood of pregnancy is now X%. Okay. So what advice would you give her given her weight, right? Should you say, this looks good, you know? Your BMI is under 25, go forth. So you actually probably wouldn't, or at least you would be cautious. So she is actually just at the borderline for she is just at the borderline for what we are looking at. So she is kind of just overweight, so really should maintain or lose a little bit of weight. And this gets into the fact that, you know, depending on someone's ancestry, you have different expectations in terms of what you might expect their weight to be and what you might consider a normal weight for them. I really focus not just on weight, but on what they're actually doing, right? If they have a healthy diet, a healthy lifestyle, and are maintaining a stable weight, I am much less likely to push on heavy weight loss if they're sort of in the normal to just barely overweight category. However, if they have a significantly unhealthy diet, even if they have a normal weight, I'm more likely to provide nutritional advice. So what is the primary treatment for this girl with 8 menses per year, hirsutism by modified Fairman-Gawe score? What would you prescribe for her? So if your answer is oral contraceptive pills, you would be correct. So what I have done is put kind of what's recommended into a PCOS treatment framework for you guys. So when someone has oligoanovulation, they're at risk for endometrial hyperplasia. The things that prevent that are oral contraceptive pills and progestins or progesterone. For contraception, the things that works are oral contraceptives and progestins. And if this is in a progestin-only pill or in an IUD, and fertility concerns is ovulation induction and IVF. For the hyperandrogenic symptoms like acne, the thing that you want to do is actually block the androgens. And I will tell you that one of the best ways to do that is with an oral contraceptive pill. You can also manage associated risks. So these individuals, we already talked about their obesity. You also want to screen for triglycerides, depression, essential hypertension, and sleep apnea. You want to recognize that they may have a component of insulin resistance, which can both contribute to the hirsutism because there are insulin receptors on the theca cell that will increase your testosterone production, but also in terms of the stress they're putting on their pancreas. So Sanais asks, would a Mirena IUD be an option to prevent endometrial cancer added with spironolactone to decrease the androgenic effect? So you're correct. The Mirena IUD has a levonorgestrel containing progestin in it. We tend to think of that levonorgestrel progestin as being an androgenic progestin. And we do observe in clinical practice that women with a Mirena IUD, some of them, the vast majority are fine, but some have an increased risk for experiencing some female pattern hair loss, which we associate with mild hyperandrogenemia. However, the vast majority of women, even women with PCOS, do not see a worsening of their androgenic symptoms on the Mirena IUD. The Mirena is an excellent option for cycle regulation. The vast majority of women, somewhere between around 70%, are amenorrheic at the end of a year. You can easily use it for 7 years for endometrial protection. You could probably slide it out to 10, but 7 is where we really have the data from the endometrial side. In terms of the spironolactone, it would absolutely be added for any type of hyperandrogenemia. So I have a lot of my patients who are on a Mirena IUD and spironolactone for PCOS who are not interested currently in family building. So we just talked about the oral contraceptive pills as being first line. As a reminder, we do think women who are older, over the age of 39 or 40 and are obese, are at an increased risk for blood clotting. And as a result of that, do recommend using one of the 20 microgram, which we consider kind of low dose oral contraceptive pills. This is actually a wonderful table that is actually from the hirsutism practice guidelines. I find this extremely helpful when I'm counseling my patients and when I'm thinking about what type of oral contraceptive pills I'm choosing. This is the generation of progestin, the relative androgenicity, the relative venous thromboembolism risk related to the progestin, not related to the ethinyl estradiol, and then the variety of progestin doses. And I think what you can very clearly see is some of sort of the fourth and further anti-androgen progestins actually have the highest absolute risk of venous thromboembolism. As a result, I'm actually much more likely to go back to our old friend of a first generation progestin, which is norethindrone, and use this. This is commonly in the United States marketed under microgestin or Junel as two of probably the most common ones that we see. There are alternatives. We've actually already spoken about the use of an IUD. If someone is not sexually active and is not looking for any contraception, you can also use cyclic natural micronized progesterone or medroxyprogesterone acetate. And if someone can tolerate absolute none of these things, metformin is second line, because metformin, when presided with women with PCOS, sometimes, and I emphasize sometimes, increases their menstrual cyclicity enough that they have a bleed every 2 months. But this is, I would say, pretty weak in terms of being used, given the IUDs are really just so effective nowadays. So we talked about the first line of hyperandrogenemia being the oral contraceptives. In terms of the anti-androgens, the spironolactone is the one we most commonly use. Its main action is a dose-dependent competitive inhibition of the androgen receptor, but it does have some 5-alpha reductase inhibitor activity. Very, very low, but we do see it. Or there's finasteride, which is also a 5-alpha reductase inhibitor. There's really nothing else that's available in the United States. I know there are some things available outside of the United States. There is a mild risk for liver damage in finasteride, so I always monitor LFTs on my patients on finasteride. Finally, there are a lot of PCOS-associated risks that you're going to screen for. You're going to screen for overweight. You're going to screen for depression and anxiety. You're going to do an OGTT. You're going to screen for cardiovascular disease risk factors. If there are any symptoms of OSA, which is often undertreated in women with PCOS, you're going to look at polysomnography. They don't actually suggest screening for endometrial thickness. And this actually gets to Sana's question, like, is there a concern if someone doesn't bleed on a lower dose oral contraceptive pill? And the answer is, in practice, no. We think that continuous exposure of a progestin prevents the type of endometrial hyperplasia that we are concerned about. Furthermore, we know that there are sort of the way that the endometrial lining truly grows is in response to estrogenic stimulation. And so if the ethinyl estradiol and the progestin are pretty evenly matched in an oral contraceptive pill, and they're taking it every single day, there is really truly very little endometrial lining that actually grows. And that's why people describe getting lighter periods, and sometimes they get lighter and lighter over time on an oral contraceptive pill until sometimes they are not bleeding or have only spotting in between. They also don't suggest you screen for what I will say is now MAFLD or MASH, but to be aware of the possibility. And this is a metabolic steatohepatitis that we're talking about. And you should be aware, however, of the possibility. You know, practically, we are checking LFTs for other reasons, for other medications that we're putting a patient on. If you do see they're elevated, you can evaluate a FIB-4 score, which is a score that would indicate the risk for hepatic fibrosis. If you get a positive score, you can check liver elasticity. Up until probably 2 weeks ago, we did not have a drug to treat this. We do now have a drug that prevents the development of fibrosis that was just FDA approved, and that the newest was just published in the New England Journal of Medicine, the randomized controlled trial for it. Okay, case number 3. Patient presents amenorrhea times 4 months, interested in fertility. So this is a 27-year-old woman. She said, I have a 28-day cycle until about a year ago. My menses got a little irregular, maybe every 2 months. Menarche at age 13. Healthy diet, low fat, exercises. BMI is 19. No hirsutism, mild chin acne. What additional history would you ask this person coming into your clinic? And I can see Sanez is already going, are we looking at functional hypothalamic amenorrhea here? What should we really be asking? And, she's absolutely right in terms of digging down on exercise. We have some really nice clinical practice guidelines related to what's going on. These are from the Journal of Clinical Endocrinology and Metabolism, and were published in May 2017 from the Endocrine Society guidelines. And they suggest looking for eating disorders. Well, the patient said, I'm low carb, athletic training. So that 1 hour, 6 days a week, she actually runs 30 miles a week and does 20 minutes of weights. She's just a fast runner, which is why you missed how many miles she was putting on her shoes with her description. She has a very type A personality in terms of her focus on her weight loss. And when you ask her about weight loss, she goes, oh, I decided to do a New Year's keto challenge and I dropped 15 pounds and I absolutely love it. But don't worry, I'm sleeping 8 hours. I'm just following a super healthy diet. No particular stressors. My mood's fine. My menstrual period was regular before this. Haven't broken anything. No substance abuse. And so this is really the concept that, all of her values are quote unquote normal, right? And so she does not have anorexia nervosa. She has hypothalamic amenorrhea. And so anorexia nervosa is really a significantly low body weight that is associated with an intense fear of gaining weight or becoming fat, or persistent behaviors that interfere with weight gain. And it's really a disturbance in which one's body weight or shape is experienced. There's an undue influence on the sense of body weight and how that means. And full remission is when all of these criteria disappear. There's not a formal BMI cutoff. So if, as you're working with this patient, she's unable to gain any weight, starts to talk more about her feelings or issues, she may fit into that category because anorexia nervosa can occur in the setting of a normal BMI. So about 63% of patients would fall into this category where they have a BMI at least greater than 17, and about 40% would have a BMI greater than 18.5 and would be considered normal. So now you're going to kind of look at your lab studies really for FHA. And so here is where the clinical practice guideline is. They suggest a complete blood count, a comprehensive metabolic panel, an HCG, prolactin, TSH, free T4, LH, FSH, E2, and an AMH. I'm going to be honest, I highlighted the 2 things in the guidelines that are both extremely expensive tests and also extremely hard to interpret. So whether your AMH was high or low would not necessarily automatically change your suspicion for whether or not the patient had hypothalamic amenorrhea. ESR is getting at whether or not there's another inflammatory cause of their hypothalamic amenorrhea, but practically you would likely turn that up on a head-to-toe sort of review of systems. So in this patient, and this is actually labs from an actual patient of mine, this is a normal prolactin, normal TSH and free T4. Their FSH is 4.2 and their LH is 0.9 and their estradiol is less than 20. And they have actually a low testosterone and a low normal DHEAS. And I checked those because they had complained of sort of worsening acne symptoms. So the one thing that is very, very classic for FHA in these labs is this low LH with a preserved FSH. And it is a reminder that the reproductive axis is under dual control and regulation, such that the FSH is still receiving information from inhibin B in that young and active ovary that is keeping it in the normal range. They suggest you look at a progesterone challenge to look at the integrity of her outflow tract. Well, if she's already had a withdrawal bleed to an OCP, you don't have to check anymore. An MRI, if we look and see that there are any pituitary issues, well, there are no headaches or pituitary suspicions. And then if you're interested, you could look at a DEXA, and if it's primary amenorrhea, you should evaluate her for Mayer-Rokitansky-Kuster-Hauser syndrome. So this is my patient. She had an adult side uterus, a thin endometrium, a right ovary in a polycystic pattern, a left ovary they couldn't find with her high-fat diet, her high-fiber diet. So she has irregular menses, acne, and PCOM. So does she have PCOS? Well, PCOM occurs in up to 56% of women with hypothalamic amenorrhea because PCOM is an anovulatory appearance to the ovary. We certainly have women who have an overlap between PCOS and hypothalamic amenorrhea, but I would not rely on the PCOM, and because PCOS is a diagnosis of exclusion, unless she had these irregular menses prior to her weight loss. Right now, she actually does not meet the criteria for PCOS because it's a diagnosis of exclusion. She just meets the criteria for HA. And this is the notation that really that checking AMH, higher AMHs are associated with more follicles in the ovary, are associated with anovulation. So that's where I think that this AMH is not a discriminator necessarily for the hypothalamic amenorrhea. Okay. So Sinez is asking, could we have both PCOS and FHA and someone presenting each in one spectrum of weight? Absolutely. So I have women with PCOS who have a BMI of 20. I have women with FHA who have a BMI of 20. In general, women with PCOS gain weight per unit time more so than their non-PCOS counterparts, but there has been some lovely, lovely work done more recently about the genetic backdrop of PCOS and that there are sort of clusters of individuals who have PCOS that have slightly different genetic backdrops. One of them is much more associated with obesity than the other. So there really is sort of an obese PCOS and a lean PCOS phenotype. It's probably not quite that simple. There are more than that. But the BMI of someone does not necessarily tell you whether or not they have FHA. I have also seen FHA in women who have a BMI of 30 and lose down to a BMI of like 22. And they've worked so hard to lose that weight, but their body goes, my gosh, you dropped, 8 doses on BMI. I feel like I'm starving. And that's always a very, very difficult conversation. Okay. So in terms of recommendations, I think the recommendations that I would put forth is one, weight restorations. Those 15 pounds she lost with that keto challenge should probably go back on. We're looking for exercise adjustment, maybe running about 15 miles per week or less. And I love that Angela was like, what about support from nutrition and a licensed clinical social work? Absolutely. Nutrition and mental health are a critical part of it. The one thing that I will say, just to be careful about with nutrition, is you want to find a nutritionist who is not going to necessarily focus on counting every calorie, right? These patients already are a little bit of a perfectionist. And actually, sometimes the more you're making them count their food, almost the worse their behavior can get. And so I will say I often start with initial general nutrition counseling in my clinic, see how they respond to it, with really an emphasis on intuitive eating and on eating to replace for their intensive exercise. And sometimes that's enough to change their habits. But I just a little caution for everyone. If she was coming to you for fertility, you would provide all of these. If she did all of this and her periods did not come back and her LH was still low, your ovulation induction would not be with Clomid or Letrozole. She has inadequate LH. Your ovulation would be with FSH and LH preparations instead. So this would be something like Menopur. This is also very relevant if she were to go to IVF. If you were to refer her to IVF, you would say to your IVF colleagues, you can't just treat her with recombinant FSH alone. She requires LH support. It also means that because she has trouble making LH, she is going to require luteal phase support for, that's also really important. If she's not interested in fertility, you would recommend a transdermal estradiol patch. Your goal is an E2 level of around 100 picograms per ml. You're actually trying to restore her estradiol level to where it would naturally be with oral cyclic progesterone. I typically use natural micronized progesterone. What I've really done is essentially replace her with bioidentical hormones. And you may say, why replace her with the bioidentical hormones? Like why am I doing that? And the reason why I'm doing that has to do with bone health. If she does require contraceptive management, that's a different question. And you would have a discussion with her about that. Now, if her BMI was 17, I would actually not offer her any type of ovulation induction work. She's simply too underweight. And I would really focus on hormone replacement. If she restored her weight and she adjusted her exercise and her FSH is normal and her LH came up, then you could use the clomiphene citrate or the letrozole. And I think that's the key difference here is as you're monitoring for treatment response, depending on what happens to that LH level, depends on how you're going to guide her request for fertility. Okay, any other questions about our functional hypothalamic amenorrhea woman before I get into a case of someone who has insomnia? Okay, well, feel free to place them in the chat. So this is a 48-year-old woman who reports that she awakens with drenching night sweats 3 times a week, does not feel rested. Her last menstrual period was 6 months ago. She has a stable weight and she's up to date on her cancer screenings. She takes a multivitamin. Her BMI is 118/64. She has a normal heart rate and her BMI is 25. So her exam overall is actually unremarkable. She does report hot flashes and vaginal dryness and poor sleep and decreased libido on review of systems. So when you think about it, you know, stress, diet, and exercise habits can lead to hypothalamic amenorrhea. acne, hirsutism, and voice deepening to tumors, issues with headaches and the visual fields, the pituitary, galactorrhea, hyperprolactinemia, so she's not reporting any of these. She's not signing any signs of hyperthyroidism that explain why she's been amenorrheic, nor hypothyroidism. And she's not telling you she had some type of complicated delivery that would lead to either Asherman's due to endometritis or severe bleeding that would result in pituitary apoplexy or pituitary infarction and Sheehan syndrome. She hasn't had any recent unprotected intercourse. You don't think she's pregnant. And she doesn't have any systemic illness. So where you're left now is, what laboratory studies would you order for her? Are you going to order labs for her? Right, so Santa's is saying, is she in menopause yet? So when someone comes in and has new onset dropout, she's 48, you could say, hey, she's within the normal timing of menopause. She's got the night sweats, she's got all the symptoms. But I always double check an HCG, a TSH, and a prolactin, because I never want to miss a pregnancy, hyperthyroidism, hypothyroidism, or a hyperprolactinemia, something going on at the level of the pituitary. Her FSH here is 38. Her estradiol is less than 5. Depending upon how you define menopause, menopause is technically defined as 12 months after the cessation of menses. She's only at 6 months. Some clinical trials will use 6 months plus an FSH of 40. She's not quite there yet, but she's probably well on her way. And so if she is well on her way, she is perimenopausal to / early menopausal, and she's got drenching night sweats. So you're going to think about treating her with hormone replacement therapy. Hormone replacement therapy remains the most effective therapy for perimenopause and menopausal related vasomotor symptoms that we have. And that was recently reaffirmed even in light of new treatments that have been available by the North American Menopause Society. So what we do have to do, however, is assess her, right? So less than 10 years since menopause, or she's perimenopausal. Yes, great, fantastic. No history of unexplained vaginal bleeding, no stroke, no active breast or endometrial cancer, no active liver disease. She's not giving a history of diabetes, hypertriglyceridemia, gallbladder disease, or an increased risk for breast cancer or CVD. We'll talk about how we can present them. And she doesn't have a history of migraine with aura. So we're well on our way. The next thing to do is assess CVD risk. This is a really handy calculator that you can actually pull up while the patient is in the office. It's the ASCVD Risk Estimator Plus from the American College of Cardiology. It is tuned for individuals from the United States who identify as Black and individuals who are white. It is not as well tuned for other races. You can still calculate it, but there's always a caution associated with it. You put in the patient's current age. I filled in their systolic and diastolic blood pressure, which frankly, according to our new hypertensive guidelines, would probably be stage 1 hypertension. I filled in her cholesterol levels and her general health history. And this gives her a 0.9% or a low risk of ASCVD. We don't offer hormonal treatment to women who have a high 10-year risk, which is 20% or more. And there is a caution in individuals who have an intermediate risk, which is anything greater than 7.5%. She's at 0.9%, so she's not there. For breast cancer, this is based on the 5-year risk for breast cancer. And I like to use the breast cancer risk assessment tool at cancer.gov. And this patient's 5-year risk is 1.3%. It's below the 1.67. So menopausal hormone therapy is okay. So low CVD and low breast cancer risk. What would be the preferred method for hormone replacement therapy? So when you guys are dealing with your menopausal patients, what type of hormone replacement therapy do you use? And you can put that in the chat or anywhere. Yeah, so I see transdermal come across. I am so happy to see that. I think that is really where we are. These are the wide variety of options that we have, but I am going to tell you almost uniformly, I use transdermal patches. You know, I think the 0.1 milligram for hormone therapies is actually quite high. In menopause, I typically do not go above 0.05 milligrams once or twice weekly, which is really a dose of about 50 micrograms daily. I don't like to go above that. Below that is felt to be not significantly activating when it comes to clotting factors. So that's really the one that I go for. And then I typically use the oral micronized progesterone over the medroxyprogesterone acetate. The one caution is that it is in peanut oil. Now you can have it compounded not in peanut oil, which I have done, but you want to avoid it if it has a peanut allergy. Like any progestin, it can cause drowsiness. So I tend to have my patients taking at night. They already have disordered sleep associated with menopause. Sometimes this is helpful. The reason why I don't use as much medroxyprogesterone acetate is because medroxyprogesterone acetate was the progestin that was used in the Women's Health Initiative trials of menopausal hormone therapy. I think we can all now recognize there were pros and cons to those large trials, particularly biggest con being these women being significantly past menopause and restarting hormones after having been off hormones for a very long period of time. Nevertheless, the sort of increased risk of breast cancer that they saw was really in the arm that included the medroxyprogesterone acetate. We really do think it also was potentially involved in some of the metabolic complications. So it probably is the less preferable progesterone to be using in a woman who has a uterus. If the woman does not have a uterus, there is no indication to use a progestin or a progesterone. Okay. Sanez is saying, how do you choose a progesterone dose? For natural micronized progesterone, I typically use 100 milligrams daily for a 50 microgram patch or less, or I use 200 milligrams daily the first 12 days of the month. And I like to set it that way versus some other cycle because most people can remember when it's the first of the month. And so it's a good reminder. And if you do it that way with the 200 milligrams, you can expect a bleed. If for some reason they are getting some bleeding on the 100 microgram nightly and they have a thicker endometrial lining, you could go up to 200 milligrams daily. But typically that's my practice. So what do you do if your patient had a contraindication to hormone treatment of her vasomotor symptoms? So what do you do? What's your first line that you're offering to your patients when they have a higher risk? So I see SSRIs. SNRIs, yeah. So I'm going to tell you that on this entire list, I have starred the 2 that are FDA approved. I will tell you of these are the least prescribed currently. I would say the most prescribed are citalopram and escitalopram as SRIs, gabapentin at night, particularly for night sweats and sleep disordered bleeding, disordered sleeping related to increased heat. The newest drug on the market that was just approved, though, is fezolinetant. Now, fezolinetant remains expensive and not as well covered, but in patients who have failed other options, it remains a possibility. and it is a new class of drugs. It is an NKB receptor antagonist, okay? And so these NKB receptor antagonists are working at the level of the brain. They are working at the level of neurokinin B neurons, which are, some of whom include kisspeptin, neurokinin B, and dynorphin, are called candy neurons. Neurokinin B increases as you go through menopause. It increases because you increase NKB, you increase kisspeptin, you increase GnRH, and those are the signals from the brain that result in increased FSH and LH that try desperately to tell the ovary to signal, even though the ovary has now faded. Okay, and so that type of hyperreactivity results also in hot flushes, because that neurokinin B signaling also is directly tied to the median preoptic nucleus, which regulates body temperature. It's the part in the brain that if it gets hot, it vasodilates whatever organism it's in. So that's why women get hot flushes. And so estrogen actually feeds back onto that neuronal system and decreases those NKB transcripts. So that's actually one of the ways in which estradiol treats hot flushes. This acts directly at NKB. It acts day one, the moment you start prescribing it. You can expect about 50% of your women to see a 50% reduction in hot flushes. It is most effective in the women who have the most significant hot flushes. And it is most effective in women who are sort of 2 years out from menopause, roughly. We do not yet have data on its effectiveness in perimenopausal women because it has not yet been studied in perimenopausal women. The most common side effects that you might see are things that you would expect: stomach upset, irritation, things like that. The thing that is the one caution that you need to monitor for are liver function tests. You cannot start this in someone who has greater than 2 times the upper limit of normal liver function tests in terms of transaminitis. And you need to check an AST and an ALT, or your transaminases, at 3 months, 6 months, and 9 months on therapy. There is not currently a recommendation for yearly checking, but my current practice is to check yearly. This is indicated and has been studied in women who are more than 6 weeks post-hysterectomy, when there is an oophorectomy involved and they experience hot flushes. So that is another place where you could do it. Right now, my sort of understanding of it is really being approved because of its expense by insurance companies for women who have hormone-sensitive breast cancers. As a result of that, have either had to have a total hysterectomy or are on some other form of suppressive therapy, and in that setting have intolerable hot flushes or night sweats that are not responsive to SSRIs or gabapentin, or that they're intolerant to those, or that you want to add the NKB on top of those. Okay. I am open to other questions of fezolinetant. If anyone has them, please feel free to post them in the Q&A, and I will return to them after our next case. So case 5, amenorrhea. We have a 22-year-old woman who reports her last menstrual period was 6 months ago. She feels hot during the day intermittently. She reports some mild acne. Her menarche was age 14, and she has monthly menses. She's hypothyroid and has a history of Hashimoto's thyroiditis and is on Synthroid, 100 micrograms daily. She has a pale vaginal mucosa on exam. Her HCG is negative. She has a normal TSH and prolactin, our core things we're going to check on anyone who presents with us. and her FSH is 110 and her estradiol is less than 15. What is your primary differential diagnosis? So we think she has POI. Sanez has very astutely identified by her elevated FSH, quite elevated, and low estradiol. What do you think might be some of the sources for her POI? Are we done? Do we just say you have POI, you need not menopausal hormone therapy, but you need hormone replacement therapy until the natural age of menopause and let it go? Or do we do further testing? So the answer is we need to do further testing, okay? And the reason why we need to do further testing is because of the source of the condition. So POI is either caused by accelerated follicle depletion from a genetic, autoimmune, or some type of toxic or idiopathic exposure, or decreased steroid production, typically without oocyte loss. But the oocyte itself is non-functional, so you still get that elevated FSH. There have been now more than about 65 genes that have defined familial genetic causes, but there are some core things you have to check. So the number one thing you have to check is a karyotype. Okay, the reason why is although this woman is 22 years old, and you might think, oh, you would have already picked up Turner's syndrome. There are a number of women who are Turner's mosaics, and they are picked up in their early 20s, even into their early 30s, when they develop POI. And so it's really important to understand if this woman has Turner's syndrome. Second, Sanez has already astutely identified you're looking for autoimmune etiologies. Particularly, you are thinking about those that are associated with endocrinopathies that are associated with adrenal insufficiency, so a 21-hydroxylase antibody. You can also check a TPO antibody, and that is because someone may also have sort of a general autoimmune background, and it's more common that someone is a positive TPO antibody. In this patient, you already know. She already has Hashimoto's thyroiditis, so you already know she's TPO antibody positive, but this is for anyone you would consider it. You want to look at FMR1 repeats. So you're looking for pre-mutations in FMR1 that when expanded lead to Fragile X syndrome. You want to do this not necessarily for this woman with her FSH of 111, who really does not have any functional ovarian oocytes left. You want to do this for any of her sisters, because her sisters are at risk to have inherited the exact same pre-mutation. And the development of POI with these FMR1 free mutations are variable. And because they are variable, you want to be able to give that information. You can consider other autoimmune testing or genetics. You noticed I didn't suggest screening with a cortisol level. If the patient does not have any symptoms of adrenal insufficiency and has a normal blood pressure, there is not a current recommendation that you have to screen with an AM cortisol level. It is sufficient to check a 21-hydroxylase antibody and provide anticipatory counseling to the patient should they experience any signs or symptoms related to adrenal insufficiency. And please don't check anti-ovarian antibodies. So there's a lot of stuff out there about anti-ovarian antibodies and antibodies at the level of the ovary, but up to 31% of women with normal cycles have them, so they're not actually informative. If someone is 21-hydroxylase antibody positive, that is when I will check an AM cortisol. And in fact, I will actually formally do a co-syntropin stimulation test on them. If it is normal, I simply monitor them for symptoms rather than following a cortisol level. Okay, so her karyotype came back as a mosaic. So 15 out of 20 of her cells were 46XX, and 5 out of 20 were 46XO or X null, which means she was a single X. Her autoimmune evaluation, as expected, she's TPO positive, but she's hydroxylase antibody negative, and she had a normal number of FMR1 repeats. So Turner's syndrome, if you diagnose it in the setting of POI, really belongs in a multidisciplinary care center, okay, which should be composed of primary care, cardiology, endocrinology, audiology, dermatology, and psychology. And the reason why is because these individuals are at increased risk for a whole host of issues. So at every visit, they need a weight, BMI, and blood pressure. They have an increased risk for hypertension and an increased risk for obesity. Annually, because of their risk for hypothyroidism, which she actually had even before you diagnosed the Turner syndrome, it showed up first. They're also at risk for abnormal liver function tests, and that includes the new MASLD metabolic liver disease, diabetes, and lipids. Every 3 to 5 years, they need a 25-OH vitamin D. Every 5 years, once off HRT, they need a bone mineral density. If there are symptoms, they should be screened for celiac disease. They need cardiac screening. So although she has POI, she could use a donor egg to conceive. However, there are specific guidelines related to Turner syndrome based on their cardiac disease. And she should see audiology because she's at increased risk for hearing loss. All right, case 6. 38-year-old woman who reports no pregnancy after 6 months of time sexual intercourse using ovulation predictor kits. Menarche was at age 13. She has cycles every 30 days. Her day 3 FSH was 5 with an estradiol of 22. That's beautiful. Her antral follicle count was 12. I say good for her as a 38-year-old woman. She has a normal HSG, normal TSH, a normal prolactin, 24-hour urine serum cortisol, and an IGF-1. So what is missing from this workup? And I can see Sanas has already jumped on it. What is missing from this workup is a semen analysis, is a male partner analysis. So, 1 in 5 individuals will experience some form of infertility over the course of their lifetime. In cases with partners, somewhere between 25 to 50% of the time, there is a male factor. That does not mean it's the only factor, but it may be at least a contributory factor. So her partner is a 35-year-old male who's never fathered a child, normal onset pubertal development, mild pubertal gynecomastia, normal libido and potency, shaves twice a week with some sparse body hair, and on exam is 72 inches tall. Of note, his father was 68 and mother was 62 inches. Non-tender gynecomastia, no galactorrhea, and 8 cc testes bilaterally. So based on this history I have just given you, what do you think is his most likely diagnosis? And feel free to put it in the chat or in the questions. What are you thinking when you're seeing this? What diagnosis is this? So what if I told you his testosterone was 200, his LH was 24.9, his FSH was 40, and his prolactin was 10? So his primary defect is with spermatogenesis. And indeed, you see oligospermia, you see decreased sperm, you see teratospermia, you have lower sperm, asthenospermia, you see motility diagnosis, motility defect. He's got everything. And so here's where karyotype is going to tell you that he has Klinefelter syndrome. What are you going to tell him? Well, the good news is you are going to say to him, I'm going to refer you to urology, and urology is going to use testicular sperm extraction. And there is a decent chance, somewhere in the 50 to 70% range, that we may actually find something. Now, the caution is his FSH of 40 and his age, because we think that the ability to retrieve them goes down with age. So he may not have quite the same outcome, but that is absolutely the next best step. And I see a question in the chat about a patient who has an irregular period in their 20s and 30s. Their FSH on day 3 is slightly above the follicular phase range. And the question is about egg freezing and whether or not mild FSH elevations can be seen with PCOS. PCOS is not associated with any type of ovarian defect, and I would not expect to see an FSH elevation in someone with PCOS. For anyone who has a day 3 FSH that is above 10, I consider whether or not they have some premature ovarian aging, whether that formally meets the criteria for POI or not. And that is a case where I will often both check an ultrasound to get an antral follicle count, as well as to check an AMH level. If her AMH level is frankly low, sort of completely inappropriate for what it should be, I will have a discussion with her that I think she has experiencing some ovarian aging. Egg freezing itself is really not a panacea. I know it is out there, but eggs don't freeze well. We've developed more techniques to improve them, but by and large, eggs don't freeze well. And we actually don't know truly, although we're working with artificial intelligence to get a better sense of the quality of the egg or how likely it will be to fertilize. But we really don't know that until the egg is defrosted. And so you need a tremendous number of eggs in order to guarantee the chance of a live birth. So if I have someone who has a partner, okay, and has knows they want to have children in the future, but just not right now, I typically ask them why not right now, and then have a discussion about embryo freezing rather than egg freezing, because embryos freeze really, really well, and we have excellent data about the ability of unfreezing embryos and then implantation. So I hope that answered that question. Please feel free to put more questions in the Q&A. I think we have some time, and I can also stay later if people have any questions. I want to thank you very much for your attention, and I hope this has been helpful for you. So please feel free to continue putting things in the Q&A or in the chat, and I will answer them. All right. So I see during perimenopause and a patient having irregular periods, can we use continuous estrogen and progesterone, or does it need to be cyclic? So in perimenopause, transdermal estradiol and oral natural micronized progesterone will not stop ovulation, right? And so this person will continue to have irregular breakthrough bleeds during perimenopause. So one of the best things you could offer to this patient would be a progestin IUD, or depending upon her WHO criteria, you could have a risk-benefit discussion with her about the use of a low-dose combined oral contraceptive pill. But I think those are your two options that you have in someone with perimenopause and really bothersome irregular period bleeding that you're trying to manage. Great. Well, we have about 3 minutes left. If anyone else has any other questions, I will stay on the line to answer them. I have put up on the slide deck my email. Please feel free to reach out if you have any questions or concerns. And I know other individuals will talk about it as well. We try to vary our reproductive endocrine talks so they're a little bit different. But if you also have any questions about congenital hypogonadotropic hypogonadism, we see and treat both a lot of women and men with that. And I'd be happy to answer any questions about that as well. Great. Okay. Thank you so much to everyone who participated today. And I hope you have a great rest of the session, and I will be delivering a talk looking at menstrual irregularity and different differential diagnoses on Sunday, and I look forward to seeing many of you there. All right, take care, everyone.